Hello everyone. My presentation is about the impact of prophylactic ureteral stenting during kidney transplantation on postoperative surgical outcomes. Incidence of urologic complications after KT has been found to vary between 0.2% and 14%. The widespread adoption of extravesical anastomosis appears to have lowered the urologic complication rates below 5%. However, urological complications are still associated with high morbidity and mortality. Ureteral stents have a protective role in reducing urologic complications after kidney transplantation. The benefits of a stented anastomosis include continuous decompression of the ureter to avoid anastomotic tension, maintenance of the ureter in a more linear alignment to avoid kinking, and protection from ureteral narrowing or postoperative luminal obstruction due to edema or external compression. However, the stents can migrate, cause dysuria, and may increase the risk of developing urinary tract infection. Thus, the role of stents in kidney transplantation remains controversial in previous reports. Thus, the aim of this study was to evaluate the safety and feasibility of prophylactic ureteral stenting during kidney transplantation. The authors retrospectively reviewed patients who underwent KT between June 2016 and June 2019. The prophylactic ureteral stenting group and no stent group were compared with respect to the clinical data and surgical outcomes. Presence of immunological risks, deceased donor KT, and bladder volume under 50 ml was used as indication of DJ stent insertion in our institution. However, the decision to employ ureteral stenting was based on the operative findings and preference of the surgeon. The ureteral stents were kept in place for at least 2 weeks. The ureteral stents were subsequently removed depending on the patient's condition and functional status of the transplant kidney. A total of 42 patients underwent kidney transplantation. 17 patients were classified into the DJ group, and 25 patients into the no DJ group. Patient characteristics are shown in Table 1. ATG induction and donor-specific antibody positivity were significantly higher in the DJ group. The mean time of DJ stent removal was 44.3 days after KT in the DJ group. There were no significant differences between the groups in terms of symptomatic urinary tract infection. The time to postoperative urinary tract infection was significantly shorter in the DJ group than in the no DJ group. The development of postoperative BK viremia was significantly higher in the no DJ group. Urologic complications were significantly higher in the no DJ group. In the no DJ group, urologic complications occurred in 4 patients. Ureteroneocystostomy stenosis in 3 patients and ureteroneocystotomy leakage in 1 patient. Percutaneous ureteral interventions were performed in all patients using percutaneous nephrostomy and renoureterovesical stenting. There was no graft loss related to urologic complications. In summary, prophylactic ureteral stenting during KT may be safe and feasible without significantly increasing the incidence of urinary tract infection and BK viremia. Additionally, prophylactic ureteral stenting may reduce urological complications after kidney transplantation. However, the selective insertion of a stent may be recommended in patients with a high risk of urological complications rather than being performed as routine prophylactic stenting. Furthermore, a prospective randomized controlled study is required to confirm the duration of placement of ureteral stents after kidney transplantation. Thank you for your attention.